Anemia in adolescents, the root cause, because if you start from them, then we have adults, both male and female, and the burden of anemia lessens on the society and on the healthcare system. Thalassemia again is very important. It is one of the preventable causes of blood transfusion anemias. So what is our role as an obstetrician? And then followed by the epidemic, almost obesity in adolescents. We catch them young and we have healthy adults. So all three topics have their own importance. So I start with my own thalassemia in adolescents and overview. A very interesting, a very very vast topic. I think even a day's session on this topic would not be enough. I hope I have been able to do some justice to this topic by presenting what we as obstetricians should know about thalassemia in adolescents and what importance we actually have when it comes to having a zero rate of birth of thalassemia major children. So we start with the definition. It is a heterogeneous group of genetic blood disorders where the production of normal hemoglobin is either partly or completely suppressed because of defective synthesis of one or more globin genes. A parent must be a carrier for a child to have this condition. World over, the carrier rates are 3 to 4, but India has the highest carrier rates, up to 17%. Punjabis, Sindhis, and Gujaratis topping the list. I just mentioned that it is a major preventable cause of transfusion-dependent anemia. The focus is on the word preventable, and this is where we as gynecologists play a very important role. There are two ways of defining or classifying thalassemia. Depending upon the severity, it is thalassemia minor when the individual is just a carrier and has mild macrocytic anemia with a normal life. Thalassemia intermedia when there is moderate anemia and the individual has to undergo occasional transfusions. Thalassemia major, as the name indicates, is a severe form, and this is a transfusion-dependent anemia right from early childhood. We can also classify it depending upon the specific part of hemoglobin that is affected. If the alpha globin chain is low, it is called alpha thalassemia, and if it is the beta globin chain is low, it is called beta thalassemia. Coming to alpha thalassemia major, it causes hydrops fetalis, perinatal death, with life-threatening obstetric complications for the mother, and a prenatal diagnosis usually leads to termination of pregnancy. So hence onwards, my presentation is focused on thalassemia major, beta thalassemia major. Let's start with the symptoms and physical features. The general symptoms due to anemia, fatigue, weakness, pallor, dyspnea, tachycardia. Specific to thalassemia are the growth problems. There is slow or delayed physical growth and maturation. And then there are deformities of the facial bones. There will also be complaint of dark hue, which is because of the hemolysis, and a large abdomen because of the organomegaly. Now, why is this deformity of the facial bones? This is what a typical thalassemic baby's face is like, called the chipmunk faces. There is frontal bossing, there is depressed nasal bridge, maxillary hypertrophy, and there is overcrowding of teeth. As I go forward, you will please remember this face, that this face is what makes the child so sad, and we have to deal with the mental problems. Now, why do these bone deformities occur in children with thalassemia major? Because of anemia, the body tries to compensate by erythroid hyperplasia. There is excessive marrow activity leading to widening of the medullary spaces, thinning of the cortical bones. New bone formation occurs on the outer surface, resulting in characteristic skeletal changes like frontal bossing, prominent cheekbones, malar prominence, and a hair on end appearance on X-ray. In addition to all these changes, these young children also suffer from osteopenia and osteoporosis because of the iron overload, the hormonal deficiency, vitamin D deficiency, the chelation-related toxicity. They further worsen the bone fragility. Well, I was reading this because it's something new to me. I was so surprised because, you talk about DEXA scans in the postmenopausal women. DEXA scan is also recommended and done for these small little children, babies. How can this be avoided or prevented? By regular transfusions that maintain pre-transfusion hemoglobin above 9 grams. This will suppress the excessive marrow expansion and the disfiguring bone deformities are thus prevented. Let's talk about the pathophysiology. There are three main causes. One is because of the alpha beta chain imbalance, there is ineffective erythropoiesis, which leads to marrow expansion and skeletal deformities and the organomegaly. Because of the fragile RBCs, there is excessive hemolysis leading to anemia, jaundice, splenomegaly. And because of the multiple blood transfusions, there is iron overload, which leads to organ damage and endocrinopathies. Let's look at the organs which are damaged and the manifestations. Liver, leading to hepatomegaly, fibrosis, cirrhosis, the heart, cardiomyopathy and irregular heartbeats, arrhythmia, and even heart failure. And the entire endocrinal system, starting from the pituitary to the thyroid, the pancreas, the adrenals, the gonads, each and every endocrine gland is affected, leading to hypogonadism, pubertal delays, growth delays, glucose intolerance. And look at the incidence of the endocrinopathies, the damage to the entire endocrine system. The incidence of growth retardation is up to 70%, hypogonadism 50 to 80%, hypothyroidism 10 to 20, diabetes also in these young children because of the iron deposition in the pancreas, hypoparathyroidism 5 to 10%, and adrenal insufficiency up to 5%. So while dealing with these babies, it's not just the blood transfusion, we also have to take care of the damage to the various organ systems. Now, how do you screen and you diagnose? We start with the first simple test, a CBC. What are the features we suggest a thalassemia trait? There will be microcytosis less than 80, an MCH will be less than 27. A peripheral smear will show microcytosis, target cells. The Menzer index less than 13 suggests a thalassemia trait. And please remember that iron deficiency must be corrected before confirming thalassemia trait. So serum ferritin is also very important because a normal or a raised serum ferritin will exclude iron deficiency anemia. Then how do you confirm? The gold standard is, of course, HPLC. Hemoglobin electrophoresis is used to detect presence of HbA, HbA2, and HbF patterns. HbA2 more than 3.5% is very diagnostic of beta thalassemia trait. If the HbF is elevated, 20 to 100%, it suggests beta thalassemia major or intermediate. And then, of course, we have to go through a DNA analysis to confirm the genotype, which is used for prenatal diagnosis and for atypical cases. Besides all this, once you've diagnosed thalassemia major or thalassemia intermediate, we have to continue. We have to look at the various organs which might have been damaged by that time, or at least if not damaged, it's the beginning, we have to have a baseline on which to further carry out our how do we take care of these little children. So in a child who's short-statured or who hasn't attained puberty, or a girl with amenorrhea, you suspect hypogonadotropic hypogonadism, LH, and estradiol. When you suspect hypothyroidism, a complete thyroid profile, complaints of polyuria, dyspsia, suspecting diabetes, and OGTT, and HbA1c. For parathyroid, a serum calcium, phosphate, and PTH. If the child complains of hypertension, low cortisol levels you're suspecting, and chronic fatigue, you have to get an ACTH stimulation test to rule out adrenal insufficiency. And like I mentioned earlier, because of the skeletal deformities, they also need a DEXA scan in addition to vitamin D and calcium levels already mentioned. What are the complications? Obviously, because of the multiple blood transfusions, the high probability of getting HIV, hepatitis B and C, iron overload, again because of multiple transfusions, organ damage because of the iron overload and transfusions, skeletal deformities, and also they have gallstones. Besides all this, just imagine a small child you find running around in the gardens or the playground and the beaches. They're so excited about what new they're going to learn, what new dress, interacting. And you, on the other hand, you see a small child who is always sitting in the doctor's chamber, going for blood transfusion, multiple pricks to the labs. They start thinking there's something wrong with them. They have suffered from low self-esteem. They're anxious that why is it me? Why I look different from the others? Why am I so short-statured? Why have there so many issues? They have depression, they have behavioral problems. The quality of life becomes so unfavorable. So besides the physical deformities, and the various tests, we have to deal with their mental and emotional health challenges also. The physical demands are so great, but the child is unable to manage. The impact on the family, besides the economical burden, the guilt that are they responsible, the parent, could they have done better? They are unaware of what is happening around. Why is the child suffering? Where have they gone wrong? How do they manage this? They need support from the society, from the healthcare system. And that is where the social support and professional guidance comes in. Now, of course, there are mobile and web-based apps, and there are thalassemia societies where the parents and the caretakers are given counseling, and they are told how to manage their child and their family. How do you manage such a baby? The goals of management, of course, is a regular blood transfusion, maintain the pre-transfusion HP at 9 to 10 so that it suppresses ineffective erythropoiesis and bone deformities, regular iron chelation therapies, manage the iron overload complication. Besides all this, you have to keep managing counseling, a regular follow-up, keep a watch if the child is not growing, delayed growth. Such children might actually need an HRT. They need to be vaccinated very thoroughly and regularly, take care of the nutrition and bone health, psychosocial and educational support, offer them curative options, hematopoietic stem cell transplants. As they grow, reproductive and sexual health, talk about hormone therapy, fertility preservation, of course, gradually transition from a child to adult. Hypogonadism is a major problem in patients with thalassemia major, and the cause is the iron deposition in the pituitary gonadotropic cells. So sometimes even a pituitary MRI is needed to detect all causes of why the child is not growing. Coming to thalassemia major and pregnancy, because of the improved survival rates, more and more women are reaching the productive age group. Such a patient requires a multidisciplinary care. Before she plans a pregnancy, you need to evaluate her heart, liver, endocrine, her iron, her ferritin levels, the challenges of multiple blood transfusions, iron overload, cardiac hepatic dysfunction have to be taken care of before you say, yes, go ahead and plan a pregnancy. Now, this is a very important part. Not only a patient, now you have a patient who's already been diagnosed with thalassemia major, that's a different story. You have a young girl, a young woman, or a woman coming to you and she's pregnant. The first step is to go and get her CBC and HPLC advice. We generally advise the couple, both the husband and the wife. Why? Because you tell the lady to get her HPLC CBC done, she'll come back to you after 3 weeks. She is thalassemia minor. You then tell your husband, and he takes a month or so, and by the time already such precious time has been lost. So advise the couple to go for a CBC and HPLC. If positive, if both are carriers, offer a prenatal diagnosis. A CVS is done at 10 to 12 weeks and amniocentesis at 15 to 18 weeks. If positive, advise termination. Further on, DNA mutation analysis for beta globin chain is also a very essential step to be carried out. What is the importance in adolescence? Early identification before marriage is very crucial. So screening in school and colleges is a must. So that this young individual can have informed decision, a genetic counseling is advised. We build awareness about the future reproductive implications. Now we have the Rashtriya Bal Swasthya Karyakrams and the Rashtriya Kishore Swasthya programs. We have so many adolescent clinics at school level, college, premarital and preconception screening. These are all very important screening programs. These are preventive strategies so that ultimately we have no birth of a baby with thalassemia major. What is our role as health professionals? We must implement screening for every girl who visits us, whether it is pre-pregnancy or she's already conceived, even a young girl who's come to us for whatever reason it might be. Provide them with correct genetic counseling, facilitate prenatal diagnosis, access, make it easy for them where to go for a CVS, where to go for an amniocentesis, promote thalassemia prevention policies. A word about thalassemia minor in adolescents. They have a normal life, but the importance lies in genetic counseling and prevention of thalassemia major. They themselves do not require any treatment, but identifying them allows for awareness and appropriate partner screening before marriage or before conception. Counseling these adults, counseling these adolescents about the benign nature of the condition, avoidance of unnecessary iron therapy. Before you prescribe an iron, get a serum ferritin done. Only then advise her iron therapy. And the importance of screening their future partners plays a vital role in breaking the chain of severe thalassemia births. The take home message is it is preventable, though not curable. And it is the adolescent screening which is the cornerstone of prevention. Genetic counseling prevents affected births. Integration of prevention and screening programs in adolescent will help again birth of a thalassemia major baby. So thalassemia may test their bodies but can never limit their spirit. Every transfusion, every treatment is a step towards a tomorrow where every adolescent can live freely and fully. Thank you.